Every access procedure begins with rubber dam isolation. To do an endodontic procedure without a rubber dam is practicing below the standard of care. Isolation should not be a difficult, time-consuming event. If you have the right setup, this should take less than a minute. Only 5 rubber dam clamps are needed for virtually any tooth you will need to isolate. The number 9 clamp is designed for anterior teeth, difficult premolars, and previously prepared molars. You'll notice the serrated clamp jaws in most of these clamps, making their purchase on the tooth structure more secure. The number 1 clamp is very strong. It's the ideal clamp for most premolars. The next 2 clamps are a pair, the 12A and 13A. These are designed for upper molars. You can see one jaw narrower for the palatal side of an upper molar. The other jaw is wider for the buccal surface. However, these clamps are also the ones I use for lower molars. The last clamp is the 8A. It's a deep-reaching clamp that allows us to grab teeth with little coronal height. I prefer using the Nygaard Ostby rubber dam frame as opposed to the Young's frame. It creates a better seal around the patient's mouth, it more effectively pulls their lips away from the operative field, and it is more facile to use during intertreatment radiography. An alternative is to use the Handy Dam by Tulsa Dentsply. This procedure should take less than a minute. Once the assembly is placed on the tooth, I floss the dam between the contacts if possible. Sometimes that is impossible, especially when a bridge abutment is being isolated. In those cases, seal around the isolated tooth with ultra-dense blockout resin. Simply syringe it around the edges of the dam and light cure it for 10 seconds. This will create a seal that is impervious to saliva and will keep the irrigating solutions from a patient's mouth. Cutting access cavities in teeth is truly a difficult procedure to do well. If you undercut the opening, you will risk file breakage or worse, miss a canal, which will cause certain failure regardless of how well you treat the other canals. If you overcut the prep, you've increased your chances of perforating the tooth, causing its immediate loss, or you will simply set the stage for mid or long-term failure due to vertical fracture. Beyond these issues, the quality of the access cavity you cut will greatly influence the experience you will have throughout the rest of the procedure. When you cheat the access procedure, you will pay the price through the rest of the case. If the access preparation is done ideally, the rest of the procedure can be done with much less effort. Access in maxillary anterior teeth begins with a number 2 surgical length carbide round burr. Do not use a number 4 round burr in anteriors and premolars. It's too big for those teeth. I'm going to start by making a cingulum to incisal cut. I want it centered mesial to distal in the tooth, coming from the middle of the cingulum to just shy of the incisal edge so I don't cause an aesthetic compromise. Just after I get through the enamel or the cast restoration, I'm going to take a very close look and make sure I like the position and the direction of the access beginning. This helps me easily correct at the start of the procedure, and because of that initial check, I can usually hit the pulp chamber the first or second cut after that. In anterior teeth, be certain to look for the pulp chamber under the cingulum rather than in the buccal direction. Most access perforations in anterior teeth are cut through the buccal surface, so if you have any doubts about buccal to lingual direction in a calcified anterior tooth, head more to the lingual. As soon as I enter the pulp chamber, I'm going to put the round burr away and complete my access with the LA Access diamond burr, as round burrs make irregular access cavity walls and generally overcut the preparation. The LA diamond burr is pushed into the pulp chamber, is rotated to cut just shy of the incisal edge, is pushed into the canal in the long axis of the tooth, and is then tipped back into the cingulum. Notice that in the first 15-second cut, we have completed nearly 85% of the access preparation. Classic anterior outline forms recommended in most textbooks show triangular shapes to cut tooth structure coronal to the common mesial and distal horns of these pulp chambers. But I think this is a needless waste of good tooth structure. Instead, if these pulp horns are present in the tooth I am entering, I cut a slot-like outline form as previously described, and then unroof these pulp horns by holding the burr or ultrasonic tip at an angle, thereby beveling off the pulp chamber roof coronal to the horns. Round-ended ultrasonics like the Buck one made by Spartan Obtura Company are exceptional for this. This ensures that I don't leave any tissue remnants and don't run the risk of having any darkening of the tooth after the endodontic treatment is completed, but retains the maximal structural integrity of the tooth. In mandibular anterior teeth, I'm going to create the same access outline form as I do in maxillary anteriors. I start with a number 2 round burr, being especially careful to limit the mesial to distal enlargement due to the narrowness of these teeth. Again, I cut halfway into the cingulum and shy of the incisal edge. Be careful to keep the preparation very shallow at the incisal extent. Here's the LA Access diamond burr. I'm not going to move it side to side, only in a buccal to lingual direction. I enter the pulp chamber with a pilot tip, rotate it up short of the incisal edge, drop it into the canal if possible, and then tip the burr into the cingulum. It's critical that you cut adequately under the cingulum because these teeth often have 2 canals. You can see that I have 1.25 to 1.5 millimeter access width. If you have less width than that, you are going to have difficulties during obturation. More than 1.5 millimeters and the tooth will be unnecessarily weakened. When completed, the access preparation should allow a file to be placed in the canal and stand relatively straight and unflexed as it exits near the incisal edge to accept rotary instruments without undue cyclic fatigue. The design objectives for posterior teeth are fundamentally different than those for the anterior teeth because the occlusal surfaces of posterior teeth are not centered over the root structure, but are skewed to the buccal on upper teeth and the lingual on lower teeth. While it may seem logical to center the access cavity in the occlusal table, this will inevitably result in over-preparation on the idling cusp side and under-preparation on the working cusp side. Therefore, the objectives that I set for my access cavities in posterior teeth are to cut right up to the working cusps and to stop short of idling cusps by 1 to 2 millimeters. Obviously, in bell-shaped coronal structures seen in some second molars and many third molars, it may be necessary to cut the preparation to both working as well as idling cusps. Premolars may have 1, 2, or sometimes 3 canals. When they have 1 or 2 canals, I cut slot-like outline forms. While many textbooks recommend round access preparations for single-canal premolars, I disagree as this does not take into account the ovoid shape of their pulp chambers and the significant buccal and lingual fins projecting off the primary canal. When it is discovered that a premolar being treated has 3 canals, and I hate those teeth, the access cavity must be enlarged at the buccal extent toward the mesial buccal and distal buccal line angles to allow entry and treatment of the MB and DB canals, therefore resulting in a more triangular outline form. Just like in anterior teeth, the line angle extension of the access cavity should allow straight, unimpeded entry paths for rotary files to avoid premature breakage due to cyclic fatigue. Using a number 2 round burr, a number 4 is too big, maxillary premolar access preparations are begun in a straight line between the cusp tips, at the angle of the long axis of the tooth. Because the working cusps on upper posterior teeth are on the palatal side, I'm going to cut to that full extent in the buccal to lingual plane. As soon as I get through the enamel, I take a good look and I see that my initial preparation is off-center. I'm a little too far to the mesial at the buccal extent. Because I checked this early on, I can still make a small correction here and find the pulp chamber without wasting tooth structure. That looks good. Now I'm headed for the pulp chamber. As I said before, this initial check seems like a small thing, but it makes all the difference. I spent years heading to the center of the tooth before checking my position and direction, making it all the more difficult to correct when necessary. I penetrated into the pulp chamber over the 2 pulp horns. I'm going to drop the tip of the LA diamond burr into one of those and cut off the remainder of the pulp chamber roof between. Again, I move the burr back and forth, keeping the mesial to distal enlargement minimal at this point. The pilot tip glides along the pulp chamber wall, defining the ideal access form. I end up with an ideal mesial to distal dimension just from the width of the burr. The buccal to lingual dimension is accomplished by dropping the pilot tip of the LA burr into each of the orifices and tipping it to those appropriate extents. Now, in very little time, I've created a smooth, continuous access form from the occlusal surface directly into each canal. I'm always interested to see what's in between the 2 canals in the isthmus area, and cutting a little deeper will aid the work of my irrigants in cleaning things out. Usually, if I take a round-ended Spartan Buck 1 or 1A ultrasonic tip and cut a bit down into it, I can find what is in essence the pulp chamber floor. Nice. This is really ideal, and it took less than a minute. Note how the files are standing out of the access cavity, skewed in relation to the occlusal surface, but centered relative to the buccal and lingual surfaces of the tooth structure. As is typical, the idling buccal cusp is nearly even with the buccal surface, and the abraded lingual cusp is 1/3 of the way in from the lingual surface. Access into maxillary molar begins with a number 4 round burr. A number 2 is too small, and a number 6 is too big. This access begins in a straight line between the mesiobuccal and palatal cusps, but is at the angle of the mesial surface of the tooth. This is critical. Do not head in at right angles to the occlusal surface. At the least, a large ledge will be created at the base of the mesial access cavity wall, and at worst, it is possible to cause a mesial perforation. To figure this angle out, take a look at the straight-on pre-op radiograph. Also, set your burr up against the mesial tooth surface, get a finger rest, and then start by cutting a slot between the mesiobuccal and palatal cusp tips at that angle. Once I pass through the enamel, I'm going to check very carefully to see if I like the position and the direction of this initial burr cut, so I can correct any error without consequence. We see that it is parallel to the mesial surface of the tooth, and the angle looks good. I'm up to the working palatal cusp tip. I'm 1 millimeter or 2 away from the idling mesiobuccal cusp tip. Ideal. And now my next objective is to cut at that position and angle until I drop into the pulp chamber with the round burr. Classically, round burrs have been used to unroof the pulp chamber of molars, but I highly recommend against this practice, as it inevitably results in overenlargement as well as rough, irregular access walls. As soon as the round burr drops into the pulp chamber, its use is over, as the LAX diamond burr is not only capable of finishing the preparation, but is more suited to this purpose. The LA Access diamond burr has a non-cutting end like many other access burrs, but it is unique in its radiused projected pilot tip as well as in its small tip diameter. The other safe-ended access burrs with large tip diameters cannot penetrate into small canal orifices, leaving a ledge at the orifice that requires further refinement with another instrument. In addition, the LA Diamond burr's small extended tip geometry acts as a gimbal around which the burr can be rotated to extend the line angle of the access cavity from the orifice level to the cavo surface in one efficient movement. In anterior teeth, this translates into rapid development of ideal access form. The LAX burr works better with the water spray on, but this is an extracted tooth demonstration, so you will see it used dry. But in practice, I always have the water spray on for several reasons. First, my burrs cut faster, they last longer, the tooth structure is less likely to have microfractures afterwards, and finally, I don't really need to see what the tip of the burrs are doing because the tip guides it around the pulp chamber periphery. This is how close I am to final access form in my first burr cut. It took about 15 or 20 seconds, and all that remains is putting the burr tip into the distal buccal orifice, tipping it up, into the palatal orifice, maybe dropping into the palatal canal a little bit, gimbaling it up to that cusp tip. See how I am coming in at an angle, getting into the orifice, how I cut into the canal a bit, and then tip the burr up to the cavo outline form I've already cut. This makes a smooth, continuous line angle extension from the occlusal surface to the canal itself. Now I am extending the mesial wall back, flattening it in preparation to look for the MB2 canal. After the outline form and line angle extensions are completed, I'm done with the LA access burr. If I have any challenges, any rough surfaces, if I have any buccal, lingual, or distal pulp horns, any further work is done with a round-ended Spartan Buck 1 ultrasonic tip. You can see I'm cutting out a trough in a straight line from the MB1 orifice towards the palatal orifice to look for the MB2 canal. The advantage of using a round-ended versus a sharp-ended ultrasonic tip here is that I'm not going to make a groove in the pulp chamber floor, which actually can mimic an MB isthmus. When these grooves gather dentin dust, they can confuse a clinician into following this pseudo-isthmus into the furcational area. Now remember that these MB1 and MB2 canals often curve as they come into the pulp chamber, sometimes by as much as 45 degrees. So when you reach the pulp chamber floor and start looking for MB2s, do not look further apically. You need to look for them in a mesial apical direction. I've cut at that angle and am now directed into the mesial canals. This is the Buck 2 ultrasonic tip by Spartan. I call it the floor sander. This in-cutting tip is going to help me flatten the pulp chamber floor. Very helpful in removing attached denticles. It's also going to unify the dentin color of the pulp chamber floor. Pulp chamber floor color is a big tip-off as to whether you've gotten rid of all the attached pulp stones, as well as indicating where to look for calcified canals. Pulp chamber floors and molars are typically a grayish-yellow color, and calcified dentin is a whiter color. Here's the final test. Can I put a file in each line angle at the cavo surface, then smoothly and continuously drop into each of the canals? Notice how this access cavity does not go distal to the buccal groove. That's unnecessary. The mesial wall at the cavo surface has been cut to within 2.5 millimeters of the mesial surface of the tooth, so that entry into the mesial canals is possible. The palatal line angle of the preparation is cut to that cusp tip, and the mesial buccal line angle is held 1 to 2 millimeters shy, and the distal buccal line angle ends up right about at the central fossa of the occlusal surface. The final access example is done on a mandibular molar. Access preps and mandibular molars are initiated with a number 4 round burr, but the initial access direction on lower molars is the opposite of maxillary molars. These accesses are begun in a distal mesial direction, and I typically put the number 4 round burr in the central fossa of the occlusal surface and cut toward the mesial. I use the same landmark for the mesial wall position as upper molars, about 2.5 millimeters distal to the mesial surface of the tooth. Again, I must make sure that my round burr is angled parallel to the mesial surface of the tooth. I do not head into the tooth at a right angle to the occlusal surface, or I will ledge the mesial wall, or worse, perforate it. So let's watch this access develop. I'm going to make a burr cut through the enamel and then check it, as with the other demonstrations. I want to stop the distal extent of this access to be no more than a millimeter past the buccal groove. You see here in the mirror, I'm a little shy of the mesial extent, and I don't want to take it any further in the distal direction, but I am centered buccal to lingual in the tooth structure. This means that I am closer to the buccal working cusps than the lingual idling cusps. After making this check, I should be able to enter into the pulp chamber in the next move. You can see here that there is a very tactile sense when I drop through the pulp chamber roof. This finishes the round burr's work. It's time to bring in the LAX diamond burr. We can see the LAX diamond burr dropping into the distal canal, righting the pulp chamber floor. Now it's cutting to the mesial, closer to the buccal cusps because they are the working cusps of lower molars. Now the LAX burr at the mesial angle of the tooth is defining the mesial extent of the access cavity as its pilot tip guides the cutting surfaces along the periphery of that part of the pulp chamber. As usual, the first LAX burr cut accomplishes 80 to 90% of the final access form. If the mesial orifices are big enough, I can enter them with the LA diamond burr placed at the angle the canal enters into the pulp chamber, allowing me to drop into each of them a millimeter or two, followed by rotating them up to the line angle extension at the cavo surface. If the canal orifices are too small to allow the 0.2 millimeter pilot tip in, then I'm going to open the orifices up with a number 15K file and/or a Spartan Buck 1 ultrasonic tip. I usually use ultrasonic access tips dry because I need to see where they are working. When the mesial orifices are big enough, I come back in with an LAX burr because that's going to create the smoothest, most funneled form into each of the orifices. What we see now is the Buck 1 ultrasonic tip being taken in to bevel off the pulp chamber roof of the buccal pulp horn. Again, although it is still taught that we should cut the access cavity to the full lateral extent of these pulp horns, this needlessly wastes tooth structure. Because we've already achieved the functional requirements of file path creation, having smooth, straight entry into each of the canals, we've reduced the chances of breaking our rotary instruments. So there's